Good afternoon. Selena, are you there? I need to apologize to you. I gave you a new last name. That's what happens when I'm typing stuff off my memory. I'm like, why did I say Pacheco? I typed Pacheco on the assignment. So my bad. I'll fix it. At least I remembered I did that, right? Yikes. Here, I pride myself on knowing you and knowing your names, and then, you know. Are you there, Selena? Oh, there. How's everybody doing? Busy? Working hard? Are you learning a lot? Yeah.
Miss Erickson, just so you're aware, I'm here with Brett. We're on the same computer.
Okay. And is that Thomas?
No, it's Tom.
Tom? Note to self, right? It's not Pacheco and it's not Thomas. Okay. Is Trevor here yet?
He's She's having internet issues. I just sent you a message.
Just saw it. Okay, cool. Okay, and not cool, but I mean, thank you for communicating. Okay, so a couple of announcements. We're in week 7 now. So week 8 is next week. We're gonna have all grades updated. And then from Friday, on Friday of next week, Mrs. Severson is going to be posting a forum, like in the nursing students, an announcement for you to go in and look at all your grades and then put in there that you have reviewed your grades for the midterm, okay? So watch for that. Next week, we are going to be having a quiz on central perfusion and exemplars, okay? So that will be in Blackboard. So study for the quiz for next week. And we'll start off today with your team presentations on your cardiac defect, song, rap, poem, story, you know, your creative presentation of a cardiac defect, right? And those have been submitted to discussion board, so I can go ahead and grade them and then watch for, you know, the grade details. I'll continue to give you feedback. Okay, how did that work for the previous assignment? Was everybody, you know, if you weren't able to get in there and if you didn't know where to look for your feedback and you feel like you didn't see your feedback, let me know, okay? You know, I usually like to give you like one thing to kind of focus on to make it, you know, that you could work on. I don't like to overwhelm people because, you know, overall they were pretty good, you know, for especially considering like they were like one of your first case studies that you'd really done, right? Where you were using nursing process and, you know, doing a plan of care, you know, identifying, you know, doing that assessment. Just remember that anytime that you're going to develop a plan of care for the patient, it has to start with that really thorough assessment. The better the assessment, the better you're going to identify priority diagnoses, and, you know, the better you're going to be able to intervene because you're going to know the way they learn. You're going to know, you know, all, you know, more about the patient holistically. So if you're going ahead with the plan of care and then later on you find out that there was something that you hadn't assessed correctly, and now, you know, it could totally change your priorities. And you know, nursing process is an ongoing process, right? You assess, you identify your priority diagnoses, you do your interventions, you reevaluate, do those interventions work? And now what are the new priorities? And then you just continue, right? So we use case studies a lot throughout the nursing program. And after you do your presentations, we can look at Mad Minute doing some more ABG and how we interpret ABGs and how we look at compensation. And then I have lecture, and then I am going to prep you out for another case study kind of activity. And this one's going to be on our central perfusion exemplars. Okay, so we're going to look at stroke and myocardial infarction and DVTs and you know, those kind of, I have a few case studies for you, so that I'll prep you out on. Okay, so that being said, let me see if I can share the screen here, okay, and go to our discussion board, and maybe not. Let's see. There it is. Maybe I can get into Blackboard from here. Okay, let's start with ASD, BSD, so atrial septal defect, holes in your heart, right? So cute. Wait for it. Come on, come on, come on. Load, load, load. I can see it.
Would it be easier if we just shared our screen? Not, this isn't my group, but would it be easier if we just shared our screen with their presentation?
Sure, maybe we'll do that. Let's see, I got it right here though. This is gonna work. Watch, there we go. Okay.
Okay, so we decided to write a story, and this is how it goes. There once was a little duckling born with a congenital heart defect in which there was a hole that was not supposed to be there and increased his pulmonary blood flow. This hole made it difficult for the duckling to eat and play with his siblings without becoming out of breath. This made it hard for him to keep up with his siblings who were born without this heart defect. The duckling was sad and wanted to eat and play with his siblings. Mom duckling reassured this little duckling that one day soon he will be able to, because eventually his hole would close on his own, or he would have a surgery to fix him right up. But before that could happen, he would have to go to the doctor so the doctor could hear the sound his hole makes and run a few tests like an echocardiogram or take a picture of his heart, called a CT scan, to check on his hole and how decreased his cardiac output was. When the doctor listened to the heart, he could hear the harsh murmur starting at the S1 and continuing through the S2. In the meantime, nurses had to assess his heart rate and his blood pressure while noting changes to his feathers, light color, and temperature. Then one day, Mom Duckling got a call from the little duckling's doctor saying the hole has not closed on its own and he was going to need surgery to close his hole in his heart. Little Duckling was nervous about the surgery, but Mom Duckling assured Little Duckling that it would help him so that he could lead a normal life with his family without fatigue or shortness of breath. Hang on, I gotta move. Can you scroll it down a little bit?
Mhm.
This made Little Duckling not so scared anymore. So Mom Duckling took Little Duckling to the hospital where the doctor closed the little duckling's hole by taking a section of the pericardium to make a patch. He is now able to run, play, and eat like his siblings with little risk for further complications.
Yeah, I tell you, I can't help but think that, like over at Banner, where they, in pediatrics, wouldn't this be a cute little children's story to explain pre-op? Maybe they have to explain heart sounds and that kind of thing, for kids. Child life could like maybe edit it a little bit, but I think this would make an adorable children's story for them to, and then they could have the little pet duck, like a little stuffed toy duckling that goes with them to surgery. I think we're onto something here. Nice job, guys. That was adorable. Of course, the peds nurse in me just loves that. So, round of applause. Yay. Okay. Moving right along. Do you have, next team, do you have yours pulled up? If I make somebody co-leader? Do you have it or no?
I've got it pulled up, but ours is very simple. Or I think we're team 4 actually, so
Okay.
never mind. We are next down on the list.
Mm-hmm.
Yeah, it's just a PDF, so it should be really easy. Okay. Sorry, I'm blocking Tom. All right, so ours was Tetralogy of Philo, and it's a poem. I am special, I am rare. Help my family understand my care. I can survive with surgical repair. Blood going to the lungs flow slow. Blood mixing in the ventricles, oh no. Aorta collects blue and red blood. Right ventricular hypertrophy. These are the things that make baby blue. And baby may have abnormal heart sounds too. Make baby cry, make baby want to die. If I turn blue, turn me on my side and push my knees up to my chest. I need surgery, I need help. I need oxygen. Baby can't move.
Okay. I'm just gonna mute just for 1 sec, guys. Sorry. Okay, sorry about that. Okay, so explain to me, just for review for everybody, what are the 4 defects? So tetralogy, right? Tetra means how many?
4.
Yes.
So the 4 defects are in our second stanza, I believe.
Oh, there's a second stanza. Yay, perfect.
Yes.
Do I keep
So-
going? How do I get there?
Oh, it's right there. It's like the second paragraph of 4 lines. So blood going to the lungs flows slow. So basically, there's a backup of blood going to the lungs. That's why you turn cyanotic and stuff, is because no matter how fast your heart's beating, your blood is going to be backed up in that area. And then the part of the reason for that is that blood mixes in the right and left ventricle. So that's our second line, because there's a hole in between the wall there. So it allows blood to mix. So you're getting unoxygenated blood going into your left ventricle, which is then pumping out into your body unoxygenated blood, which is no help to you or your tissues or your brain or what. Then the third thing is that the aorta is malpositioned, I suppose. So the aorta is collecting blood
Overriding,
from,
right? Overriding aorta.
yes. So it's not where it should be. And then right ventricular hypertrophy. So it's going to be stiff, not able to pump as effectively because of how hard it's trying to work for this baby to be around. So you end up getting hypertrophy, which means that it's just not able, it's really stiff and tight and not able to contract normally.
Right, because the heart's working harder, so the muscle becomes bigger, but in a bad way, right?
Yeah, it's not always better to be stronger.
Yep. Very good. Okay. Yeah, I like that. You're right, but you're explaining what happens in the body, which is perfect. But I wanted like the overriding aorta, not that you had to do that, but I just wanted to connect what you're saying there. We need to interpret the poem, right? And how it affects. So yeah, just make sure that you're connecting each line, like as we're learning it. I want to make sure all the students understand what defects are causing these things.
Yeah, I hope that cleared it up.
Okay, I think it did. Okay.
Okay.
So, nice. I'm liking these. They're fun. You put some thought into them. Okay. Let's see. I think I can go back actually. Truncus arteriosus. Say that 10 times fast. Truncus arteriosus, truncus arteriosus, truncus arteriosus.
So for this one, if you click the PowerPoint, I think what we're going to do is discuss the PowerPoint, not the YouTube video. I just put
Right
that
here?
as an example.
This one?
Yeah.
Okay.
Yeah.
Now I
That's
want to
if you
see.
wanna-
I didn't see it
yeah.
yet. It's
That's if
funny.
you want to go back later and watch, but yeah, I'm not singing in front of the class, so Tom gets to do that.
Yeah, I'm the talent. Morgan did great. I hope nobody watched it so that they don't know what this could have been when they get me instead.
Oh, I can't wait now.
I have Zoom fright for singing, so I just like, yeah, it's Tom's job now. I'll present. Once it loads, sorry.
Oh, why isn't it sharing? I can see, I'm like, hello, I can see it. Sometimes as I do it, then I can see it. And then all of a sudden I realize on my other screen, it's a good thing I got two computers. Oh, there we go. Okay, there.
So for our project, we decided to do a remix of the song Old Town Road. So pretty excited for this. But what we're discussing is truncus arteriosus. It's a congenital heart defect that occurs when the blood vessel coming out of the heart in the developing fails to separate completely during fetal development, leaving a connection between the aorta and pulmonary artery. And if we remember what we talked about last week, the aortic artery and the pulmonic artery both have their function. One goes out to the lungs, one goes out to the body. So when there's this hole in the heart, what happens is this oxygenated and deoxygenated blood mixes. And so blood is being pushed to the lungs and pushed to the body, both oxygenated and deoxygenated, which means that the tissues aren't receiving enough oxygen, which ultimately, if this isn't treated with surgery, it can be very fatal. Some symptoms are cyanosis, hypertension, edema, heart murmur, specifically a systolic heart murmur, and a lack of interest in eating just because the baby is feeling so poor. So this is most of the time is specific to infants because it is a congenital heart defect. And without surgery, most infants can keep living with this condition. And if you go to the next slide, here's for my visual learners. On the left, the normal heart, and on the right is the truncus arteriosus, where that oxygenated and deoxygenated blood is mixing, causing pull in the picture. And that you see is getting pushed out to the body and out to the lungs. And then, yep, now time for Tom to sing.
All right, so this is to Old Town Road, and I apologize in advance. And please, no one record this a special, extra special or anything like that. Yes, thank you all for pulling out your phones.
Yeah, and Miss Erickson, if you want, I posted the lyrics, so if you want to put those up, other people can see them as well. They're right below. It's the second link down, not the YouTube video. The second link down. Not yeah. So it's.
You'd have to exit the
Sorry.
presentation and then the next link down.
Do you want me to play you the song?
No, do you have the song?
Sorry, I couldn't submit multiple things on one discussion board. I had to submit them right after each other. I did it as a reply. So it's where it says Old Town Road docs, click that. Yes, thank you.
Hey.
Brett, you got it?
No, I can't find a good version.
All right. Oh, I gotta take my patient to the surgery room. I gotta run because she cannot breathe. I gotta take my patient to the surgery room. I gotta run because her life's at stake. She's got a TA in the heart. Parents falling apart. Her lips are black and blue. She's got cyanosis too. Only has one valve hole in her heart. Take her to the NICU until we can get her heart to start. Can somebody tell me something? We can't tell the parents nothing. Can somebody tell me something? We can't tell the parents nothing. She's got hypertension, can't get her to eat. Trying to warm her up, she doesn't like to feed. edema in her body, heart murmur systolic, trying to save her, but surgery is the only fix. Can somebody tell me not something? When will the surgery begin? Can somebody tell me something? When will the surgery begin? Yeah. That was awesome! It's so
Right.
bad.
I'll say one thing, Tom, we're never going to forget that, right?
There you go.
and
If anybody remembers that
I'll tell you
truncus
something.
arteriosus means that you have one valve and one vessel, then that's worth it.
right, and I'll tell you something too. Okay, so it's a balance, right? If the baby can be maintained stable enough to grow a little bit more, right? So that then, so the risk for surgery goes down the bigger the baby can be, right? But if the baby's starting to is more unstable, then they have to go ahead with the surgery. And it's really important, especially like this time of year, right? Making sure good hand washing, that the baby's not going to get sick, because if the baby gets sick, then they can't do the surgery, right? So, and also breastfeeding. You might think, can this baby breastfeed? Yes, because we want that baby to get that nutrition and those antibodies, right? Those passive antibodies to help protect the baby from getting sick. So, that's kind of that cardiac surgeon's decision, right? Can we put it off a little bit, let the baby grow a little bit, or do we have to go ahead? Anything else on that you in terms of interpreting the song, right? And those kind of questions about any other things to add to that, or did you kind of read that same?
I mean,
Like in terms of when they do the surgery, or
yeah, most of what we can, what our research said was just, like surgery is really the only option. Like the nursing intervention stuff, there's not a whole lot we can do. We can try and keep them elevated. We can, prescribe, oxygen or administer oxygen as ordered and things like that. But it's really just kind of comfort care and trying to keep the baby from bottoming out if they're not getting that perfusion. So.
Right. Another kind of critical thinking nursing kind of aspect of this is, if you're giving IV meds, or if the baby's getting like Hyper-L parenteral nutrition, right? In normal people, if you've got like minuscule little air bubbles and things, that's going to absorb through the venous system, through the capillaries, before it gets to heart, lungs, brain. There's not going to be like an air emboli, right? But in kids with cardiac defects, if you're breaking open ampules, you have to make sure you're using a filtered needle, right? Because little minuscule things will go right into the arterial system, right? You have to make sure all the air is out. You got to be really careful with that kind of stuff. You're putting filters on your tubings, in addition to having, always, this is not the kid that you're going to hang a bag of fluid and be doing the drips, right? You're going to make sure it's on a machine that's sensing any air in the line, or that kind of, doesn't that make sense? Now that you've seen how that in Morgan, future nursing instructor, or, clinical nursing educator on the unit or something, because you just did a great job presenting. You got a great speaking voice, and I really was impressed.
Thank you.
Yeah,
Thank
very,
you.
very well done.
You should really play that YouTube link, because then you can hear her singing voice, which is actually spectacular.
All right.
You can watch it. I just can't sing in front of people, because I will literally I'll cry. I'll freak out.
Okay.
Throw it on for us.
We'll make sure that we watch it, right? We don't want to put you on the spot there, Morgan, if you're nervous. You did a great job presenting. Okay. Let's see. Open. Team 6, aortic stenosis. Boy, I tell you, you guys are raising the bar high here. No pressure, aortic stenosis team.
Okay, so when you open our PowerPoint, I'm going to sing the song first, and then I'll go ahead and let them take the PowerPoint part.
So what is this part? Oh, there we go. Okay, I see. It's just.
Yeah. So our song is, I think, the second to last slide.
Okay.
And we'll go ahead and start there. And if we have time, we'll go through the whole PowerPoint.
I'm getting this black slide. Oh, there. You guys can see it, right?
Yep.
And you want me to go through to the last slide, or are you going to present?
Yeah, second to last slide.
Wow, cool. These are beautiful. I'm like, ooh, well, there it was.
Yep. Okay. So our song is set to the Old MacDonald Had a Farm. Okay. So I am presenting, and bear with me, but here we go. My old heart, it made a weird sound. AV valve. It's all because my aortic valve with a love, or AV valve with a love dub here and a love dub there. Here a love, there a dub. Every time my heart pumps, my old heart, it made a weird sound. AV valve. My left ventricle is so stressed out. AV valve. Calcium and narrowing, ouch, AV valve. AV valve with a love dub here and a love dub there. Here a love, there a dub. Every time my heart pumps, my old heart, it made a weird sound. AV valve with a CT scan here and a chest x-ray there. My old aging heart made a weird sound. Definitely a weird sound. So if we have time, we'll go through the whole presentation on top of that. So that's for the rest of my group.
Okay. Well, we'll see. What time is it? How are we doing? You know, we do have a lot to do today, so it's so pretty. But I think that was really, really good. So and you're right, we do have a few more to get through here. So
yeah,
maybe we'll move on.
No problem.
Okay.
Lyrics to Rachel and Bridget. So that's
this was an awesome presentation. Really well done. Okay, let's see. And what is this too? These are other, oh, I see how you, okay, that's the other one. Okay. Okay, tricuspid atresia and pulmonary stenosis.
Okay, so I'm gonna play the song in the background of my computer if that's okay.
Yeah.
Since we recorded it. For tricuspid atresia is where there is either no hole or no tricuspid opening, or it's very, very narrow. It's a congenital disease, and then pulmonary stenosis is same thing, very narrow, or the flaps don't close correctly. Okay.
I just open my eyes and see a bright light. Take my first breath of air.
Do you want to
and
skip to
something
the next
right.
slide?
Doctors say my heart makes a funny sound when it pumps blood. Not enough flow, like the opposite of a flood. Worried is tricuspid atresia, pulmonary stenosis. Outside the womb, I would rather my child halitosis. Like Maybelline, I was born with it, cause my mom was obese, diabetic, had to live with it. Now shh, put your ear to the stethoscope. I'll tell you how to survive and maybe some ways to cope. Take my lungs and my heart, catch my rhythm just to start. Give me TEDs, raise my bed, check edema like I said. Use a clue, second in the hostile space. Before you should listen to hear my heart race. And if you hear a murmur, well damn, I'm screwed. That's pulmonary stenosis for sure, my dude. So you're saying my RV won't pump as hard? I could have chest pain, syncope, or even die. Do a valvuloplasty, don't give me excuses. I hear that procedure gives me a good prognosis. So treat me right with some meds, diuretics, ace blockade, somewhat to a balloon angioplasty. That's really how it ought to be. Now that I'm comfortable, please perform an echo or EKG or a cardiac cath. That's how you'll know, because I got a TA or PS outside the womb.
Yeah, so we had way too much fun.
Who is the rapper on that one?
That one was Vivian. She actually found a app where she just, because we were all gonna try to rap and put it together, but it was just too much correspondence.
Mm-hmm.
So she found this app, and you can just say the words, and it like puts the rap beat to it for you. So she did a great job, though.
Is it in the references, the app? I gotta check that out. What's the app?
It's Smule, I guess. So I can send you the link to it.
Thanks. I gotta play with that someday when I get, maybe on break, right? Christmas break is coming. I'll get to play with that. That's awesome. Learn something new every day, right? An app that helps you rap. Okay. Cardiomyopathy. So should I just click on the doc, right? Okay.
Yeah, if you can go to the end, we did a short story at the end. There you go.
Is this it?
Yes, that's it. Okay. Once upon a time, there were 3 pigs, none of which were feeling healthy. The first little pig was dilated and suffered from pulmonary congestion, was heavyset, a fast heartbeat, tachycardia, irregular rhythms, and decreased cardiac output. The second little pig was hypertrophic. He had chest pains, palpitations, dyspnea with exertion, pulmonary congestion, orthopnea, and life-threatening arrhythmias, making it hard for him to participate in strenuous activities. He also had a harsh systolic murmur. The third little pig was restrictive and was a little slower than his brothers. He also had dyspnea, jugular vein distension, peripheral edema, and liver congestion. The 3 little pigs were excited to participate in an annual marathon where the prize was a heart transplant. But before they could start training, they had to get a physical to make sure they were healthy enough to participate. While being examined, the doctor came across some strange findings on the EKG and sent them straight to the cath lab. All were put on strict low-sodium diets, low-fat diets, and they were to weigh themselves daily and had to monitor their fluid retention. To help them with these new lifestyle changes, a nurse visited them frequently. During her visits, she applied the anti-embolism stockings, elevated the bed to provide unlabored breathing, and assisted with all their activities of daily living. After weeks of home care, the pigs were healthy enough to participate in the marathon, but were strictly advised to walk it with multiple rest breaks. Because they maintained their new healthy lifestyles, the pigs were all rewarded with heart transplants, and with that, they lived healthily ever after.
Very good. So you covered so what are the 4 classifications of cardiomyopathy? Yeah, you dilated, right?
Yeah, we covered 3 of them. There were dilated, there's restrictive, and hypertrophic.
Exactly. And the other one is just unclassified, right? Or unspecified.
Yeah, there actually are a lot of classifications, but those were kind of the main ones to hit on.
And our book just kind of puts all the other ones kind of in that unclassified or unspecified category.
Mm-hmm.
It's really nice. Again, another one that you could potentially turn into a children's book, right? If I decide to do that someday, I will come back and consult you guys and you make sure that, we'll
sell the rights for them, right?
Maybe I can do the illustrations or something, poor little pigs, we can make them like a little blue pig and a little, right? Really cute. I wonder what's out there, huh? Okay, really nice job, guys. I think you all get 100% on this one because in the comments we're all really positive too. So that's great to see that you guys are enjoying this kind of an activity and just really applying what you're reading and learning and creating something. I love it. So very, very well done. So let me see here if I can get back here. I'll go here. Well, trying to see where my PowerPoint is now. Okay. So when we're looking at central perfusion, we're really looking at those coronary arteries. And how that perfusion to the heart is. Come on, share. Okay. Come on. Oh, as I'm clicking on things, it's like glitching. Okay. So 2 of our exemplars that's in our outline for the class. When we're looking at central perfusion, and it is kind of funny because they talk about central perfusion and then they have the concept of local perfusion. As a nurse, I've never heard that term local perfusion. I've always heard it called peripheral perfusion, right? So you have the coronary arteries, which bring the oxygen to the heart. And then, the blood goes out the aorta and out to the peripheral circulation. And then, you look at how does, how are the organs and all the tissues and all the cells of the body get perfused with oxygen, because all cells need oxygen. So when we're talking about central perfusion, though, we're looking at how the heart gets oxygen. I think if you saw the announcements and kind of the different sections of Blackboard, I made a comment in there about how those coronary arteries are no wider than a strand of regular spaghetti. And when we look at our diet and fat and bad fats versus good fat, right? So it's just amazing, and cholesterol and everything in our diets, that we don't have more problems with, that those arteries just don't occlude right away. And when you're this semester, I'm having students that are rotating through the cath lab, and to see them, they go in there in the morning and the stretchers are filled, right? And all these people are going in for cardiac caths and stents, and how it is the #1 killer in the United States, right? So, here in second semester, really our focus is approaching it from prevention, right? That nursing's role in health promotion so we're doing that education and that, health promotion and maintenance. So, thinking in terms of primary, health promotion, and looking at diet and exercise, and knowing, and people getting their blood work and knowing the ratio, right, of good cholesterol versus, and then secondary, right, early. So if they're starting to have angina, knowing that that's a sign before they have the heart attack, right? Looking at their risk factors and getting in, and if they have hypertension. So personally, I was going into my doctor. I had pregnancy-induced hypertension, and at that time they said, what we find is that a lot of women who have pregnancy-induced hypertension will develop hypertension later in life. So I already had that warning. And then probably in my early 40s, I would notice that at work, I would be very hypertensive. And so I was watching it and thinking, I just get stressed. I need to drink more, this kind of thing. I'm going to exercise. I'm going to diet. I'm going to, you're right, trying to get my blood pressure down. And I go into the doctor, and the MA or the TACRA, they pump up the cuff and they let the cuff out and they write down a number. And they'd write down like 120 over 80. And I'd be like, seriously? Because I've been checking my blood pressure and it's 130s over 90s at home. I'm like, so so finally one day I had asthma exacerbation. I don't get them very often, but I had a little trouble with getting respiratory infections one year. And so I went in to see Dr. Clemens, Neil Clemens, and he's just a great pulmonary doctor. I don't know if he's still practicing or if he's retired, but he was
Call him dad because he reminds me of my dad, and he calls me
right.
daughter. He's the most amazing man ever. He's so he's
So you
so
know what I'm
sweet.
talking about, right? And
Yeah, Dr. Clemens, he's my favorite.
he takes my blood pressure himself and he's like, oh my gosh, you're 140s over 90s. And I'm like, I know. And I've been trying to diet. I've been trying to exercise for like years now. And every time I go to the doctor, they write down 110 over 70 or something. And I know it's I told the doctor, and the doctor's like, well, maybe you're just nervous at work or this kind of thing. And I've been trying to cut my sodium. He's like, no, you have hypertension. He's like, you need to, I'm going to start you on some hydrochlorothiazide. And I'm like, oh, I don't want to be on medicine. And he's like, and then you know what he said to me? Because you're going to love this, Monique. He said, it's not so much that you have to go on medicine, because what you're telling me is you've been trying this and you've been trying that. There's genetic reasons. It's essential hypertension. We don't know causes of hypertension. It can be genetic and everything. It's not so much that you're needing to go on medicine. It's that you're controlling the hypertension, right? You're getting it down and within normal, you're getting it under 120 over 80 so that you're not going to have the damage to your kidneys and the damage to your vision, right? And all those the microvascular system that gets damaged with hypertension. You don't want to have that, your heart working harder against that afterload, right? We talked about that last week and how the things that, the preload and the afterload, right? So understanding that it's not so much about having the disease, but identifying it early and controlling the disease, right? If you have hypertension, if you have diabetes, if, that's a difficult thing, right? Because a lot of times then it's the diabetic or the parky, right? The parky? Do I want to be called parky? Right? People with Parkinson's disease, they'll call them parkies. I'm like, who are you calling parky? Who wants to get labeled? Maybe some people like, like that. But personally, I think you got to call the person with an addiction, not the addict, right? Or not the asthmatic, right? Or the schizophrenic, because those things can then make us look at, it makes it less human, right? We're all people with something. We are. So I think it's really important to as we're developing that rapport with our patients and trying to motivate them to take the best possible care they can of themselves, to let them know that we value them as that holistic person and helping them realize that they can have that control, right? That education, that knowledge is power, right? The more that we know about our diseases and can advocate and speak for ourselves and what, make our best choices for ourselves, that, we do have that self-determination theory, right? They can make their choices. If it's more important to them to eat at McDonald's, they can eat at McDonald's. But I want them to understand that their coronary vessel is not, is no bigger than a piece of spaghetti, and that those vessels are the only way that their heart is getting, get oxygen to the heart. And if that oxygen gets cut off, that heart muscle is going to die. And that's going to feel like horrible heavy chest pain. They're going to have a myocardial infarction that can right there be the end of their life. Or it can mean they go in and they have to have a stent placed and then they have to be on medication, right? So is that hamburger worth it, right, for them? So, if they really could go in and see these people who, have to have that open heart surgery, that's then they are more, at least they know that you've told them, right? So that's what it means to be a nurse, right? And every time that you're interacting with that patient, just like Dr. Clemens did with me, right, is your opportunity to help them, you know, be more educated. Okay. So coronary artery disease, okay, or CAD is one of our exemplars. Atherosclerosis is this abnormal accumulation of lipid or fatty substances in fibrous tissue along the arterial wall. Okay, this is out of your book, and your book does a really nice job of explaining how this process takes place. How does this plaque build up on the insides of our arteries, okay? And how does that process of occluding those arteries begin, right? So as you get these little plaques of lipids or fatty substances and fibrous tissue along the lining of the arterial wall, it creates this inflammation, okay? So it begins with the injury to the vascular endothelium over a progress of years. That injury can be initiated by hypertension, or it can be increased lipids or other factors. And then those lipids and those other things, those little micro injuries along the injury to the interior, the vascular endothelium, the interior wall of the vessel, it leads to monocytes being attracted, and they attach on there. And then the monocytes ingest more fat and lipids. And then it creates foam cells. And those foam fatty streaks are activated. They're monocyte release chemical that also contributes to this oxidation of LDL, right? The lousy, as we like to say, right? The LDL is your lousy their fats, and then your HDL is your healthy or your good fats, okay? So you want high HDL and low LDL, and that has to do with diet, and it has to do with exercise, and it has to do with, genetics also, right? So, but we can do our best. The more you exercise and stuff, you can have higher HDL and lower LDL. And you like that, Allie? Yeah. And you really want to look at the ratio. So monitoring those numbers and decreasing your risk in that way. But as this oxidation happens and the plaque becomes unstable, then it can form this thrombus, and that's what breaks off and causes that obstruction that causes the heart attack or the acute myocardial infarction.
So would like hyperlipidemia be considered under this category? Okay.
Yeah. Hyperlipidemia is going to lead to this whole process, right? So getting on those medications, right? Those, whether it's atorvastatin or Lipitor or Zetia, right? And of course, then all those medications, usually have some side effects. They have to be metabolized by the liver, so you have to look at liver function tests and things. But and then I think the other side of that then is a lot of people think, well, I'm on this pill now that's going to get rid of this fat out of my system, and they'll eat, they won't pay attention to what they're eating as much. So, that doesn't pan out that way, right? You have to do diet, medication, exercise, and overall healthy eating. And yep. So, and then there's that whole metabolic syndrome where people have that weight around their midsection, around the heart even, and then they have diabetes, so obesity, diabetes, and hypertension, and so hyperlipidemia. So yeah, hyperlipidemia, just like you said, Allie, that family history, diabetes, gender, males are usually more hypertensive than women and at higher risk, although there's just not enough research for women also. Cigarette smoking, right? If you smoke, stop. It causes damage to the vessels, to the arteries in the body. And is it harder for someone to work out with hyperlipidemia? Not that I know of. Not that I know of. I mean, of course, depending on how high their lipids are, they'd have to follow their doctor's advice. Are they at risk for actually having it cause, a heart attack or something? So they probably want to have that initial workup and everything. Look at the vessels of the heart, make sure. But just having high fat in their circulating system, you know, the doctor would tell them probably to go ahead and start exercising to get that down. So yeah, losing weight, race, African Americans and Native Americans and certain ethnicities are at higher risk. There actually is research out there that indicates that racism in the United States is directly related to hypertension. There's been studies that show that white people or people who don't have the effects of racism, if they have hypertension, they could be hypertensive during the day, but when they go to sleep at night, their blood pressure can return to normal. Where a person who is in an environment where they feel those effects of racism, they can be like that adrenaline, right, can cause them to feel like they're in flight or fight 24/7, and their blood pressure will stay up. So, and then there's other things too, like if they're a vulnerable population, right? Then what is their access to care? What is their access to medications? What is their access to parks to be able to exercise? What is their access to healthy food and fresh vegetables and fruits? Or are they on a limited budget where then they're buying, you know, frozen foods and things that are higher in sodium? So all those things, you know, your income does equal your lifespan. Isn't that interesting that that those are other non-modifiable factors, and some, I mean, I guess they're modifiable, right? But we have to look at those types of socioeconomic factors too. And then of course, physical activity, you know, exercise is really important. And, you know, when you're nursing school, I feel like, you know, I like to say that sitting's the new smoking, right? So right? Okay, so metabolic syndrome. Think of your person with type 2 diabetes. Major risk factor for cardiovascular disease and arteriosclerosis, atherosclerosis. You have that insulin resistance. So you have this central obesity and then this dyslipidemia, the ratio of the healthy cholesterol to the lousy, the LDL and HDL. So if your LDL is less than 50 in males or less than 40 in females, and if your triglycerides are above 150, and so a student commented that like other things too that can affect your stress levels can also, you know, stress that's a great, you're right, I should put stress on there also, because that's the same type of, you know, feeling that adrenaline, increasing your blood pressure, which then leads to heart disease also. So you're right, like things like meditation, right? And yoga, in addition to other forms of exercise, stretching, right? Breath work, all those things to, yeah, you're right, stress. I should say stress, and stress is the other new smoking too. So definitely we're seeing the effects of that right now with everything that's going on in our world, right? As our world gets more stressful, it's affecting all of our health in many ways. So, yeah, so hypertension, blood pressure above 130/85. I know, it's so fun being a nurse, isn't it? Because I can see in you your passion as I'm talking about this stuff. It's like, you know, how we can impact the world and really, yeah, the role of the nurse in this. And looking at your CRP, so those inflammatory markers, the CRP and the fibrinogen levels. There's also in your book, they talk about this Framingham risk calculator, and I attached the link here. You can go in and you can look at your height and weight and other factors and look at your risk for heart attack based on that, especially if you have your triglyceride levels in your other labs. You can put that in there also. And it's kind of scary because, you know, based on these different factors, your risk for heart attack can go way up. So, you know, I think that could be a healthy tool, a helpful tool for somebody who doesn't know what their risk for heart attack is. You could just put in those numbers and show them, and they could identify the exact changes that they should be making to decrease their risk for heart attack. So preventing heart disease in the first place, priceless. Dietary measures, the physical activity, medications, right? And not knocking them for needing to go on medications. It's all about controlling those risk factors, getting that blood pressure down, getting those triglycerides down. Smoking cessation, hard, right? People need support. If they're going to choose to stop smoking, they're going to need to do it at a time when their stress is lower and they have that support, right? So how can you help them to, to do that motivational interviewing? What's it going to take to get you in a smoke-free body today, right? Managing hypertension, controlling blood sugars. I like the ads that you see on TV now. You have diabetes, you have type 2 diabetes, but did you know that can increase your risk for heart attack, right? So what is angina pectoris? Angina, that pain, chest pain, right? Chest pain is brought upon by myocardial ischemia, right? So sometimes the vessels can just kind of spasm and stuff, and they can take a nitro and it dilates those vessels and the chest pain goes away, and they'll say, okay, they have stable angina. Your next sim, I think, do you know on your lab schedule, is your next sim the stable angina sim? Is it? Yeah, yeah. So this is what we're talking about right here. And there's a whole chapter in your med-surg book on stable angina. Okay, so make sure, I think Ms. Arnold's probably gonna have that be assigned as your ticket in to review that. And some of those things that you need to know is, teaching the patient the protocol then. If they've been into their cardiologist and they're not at that point yet where they want to take them into the cath lab and do a stent, right? But maybe they have some factors that with hypertension or smoking or something, they'll get this chest pain if they overwork, and then they'll have this chest pain, but they'll have nitro. And so they take a nitro and they wait 5 minutes. If the chest pain doesn't go away, then they take another one, right? And, as nurses, we want to be checking the blood pressure because it's vasodilating. So, they may have a headache from nitroglycerin, and there's a drug that nitroglycerin interacts with. So what's another vasodilator that's out there? Does anybody know?
The little blue pill.
Viagra.
Yeah, good job, guys. Yes, exactly. How do you say it? Sildenafil or Viagra? So think of, it can also be used for pulmonary hypertension because it's a vasodilator, right? So the idea with men is it vasodilates the penile, vessels and helps them have an erection. But that same process of vasodilation, if you give nitroglycerin along with that, it can have life-threatening hypotension. So, so if you were to go to give nitro, you always need to screen and ask about the possibility that they've taken Viagra, okay? So, and angina pectoris, that chest pain is caused by significant coronary atherosclerosis, or the plaques and the things that are blocking the coronary arteries, that coronary artery disease. So types of angina, you can have stable angina that's been diagnosed and is being managed by nitro or, another medication. But really MONA, we talk about these kind of four. If somebody's starting to have chest pain and you're not sure, you can, back in the day, they used to do more morphine, but now they're really getting them more on a nitroglycerin drip or something to manage chest pain, and kind of staying away from the narcotic that can actually sedate and mask symptoms of pain. But definitely oxygen, because they want to make sure they're optimizing oxygen to the cardiac cells. And nitroglycerin is the N, so MONA is the acronym, and then aspirin, because of the anticoagulant property, right? It decreases platelet aggregation, and has been, research has indicated that it really improves the outcomes of resuscitation from myocardial infarction. So your stable angina, you're going to be managing with your nitroglycerin. But if you don't know, you could still be putting them on oxygen and doing things if they're not responding immediately. Unstable angina is when you're more considering that they may be having a heart attack. Intractable or refractory is chest pain that keeps coming back or doesn't go away. And then there's variant, and then there's silent ischemia where they don't feel that pain. And these are listed in your book too, so you can go back and kind of review each of these different types of angina. But we're really looking at that stable and unstable. So they're just kind of terminology. And then here's Mona, isn't she beautiful, right? And like I said, they're kind of getting away from, it's not like it won't be used. They still do use morphine, but they're looking more at doing the nitro and then starting a nitro drip because it's vasodilating, right? That pain is a sign that there's ischemia. Yeah, so here's where I kind of went into that, crossing out, because morphine, there's latest research about how beneficial it is. Getting that 12 lead EKG, right? I kind of went over that a little bit with the P wave and the QRS and what that indicates. So if you have, and I'm hoping maybe you're going to get this in lab too, because I've covered it in lab in the past, because that EKG, it's 12 lead because it's showing us kind of that 3D picture of the electrical activity of the heart. See how you can follow my fingers now. So when we say that, like, oh, I'm trying to think of the terms, like, if it's in the, what lead it's in will indicate if it's a posterior MI or if it's a anterior MI, or what's the other, anterior? There's two terms that they usually put together, but it tells you the location of the heart that's having the infarct. And that's what you can kind of see on the 12 lead EKG. Where is the elevated ST? So as you're seeing that QRS and the T should be below where that QRS, it should be on that same line. Like, but if the QRS, if the ventricles contract and then that T wave is high, that's an elevated ST, and that's a sign of heart attack. So you can repeat nitro 3 times, and after that, then you have to move on to your more emergency medications. You can do beta blockers or calcium channel blockers, and then you want to give aspirin. Aspirin is your antiplatelet, your anticoagulant. Make sure their oxygen levels stay 90 to 95. You want to keep the heart muscle oxygenated, and then get your cardiac enzyme markers to see if there's damage to the cells. So you want to look at tropes. They'll talk about tropes. So your tropin 1, tropin I and tropin T specifically detect myocardial injury, and creatinine kinase MB. So there's different kinds of creatinine kinase, and your myoglobin levels are what are your cardiac enzyme indicators of myocardial infarction. Okay, so the STEMI, and if you kind of can see in this little QRS here, you see where this is elevated, your elevated ST. And so this is an algorithm that they use in the, in the ERs. Somebody comes in with chest pain, they get the EKG. Is there an ST elevation? Then they know it's a heart attack, right? If there's no ST elevation, then they're going to get your cardiac markers and everything, because there's not always an ST elevation if there's been a heart attack and damage to the heart. So, so you have your STEMIs. STEMI stands for for that ST segment, elevated myocardial infarction, and you can also have your non-STEMIs, that they're still having a heart attack. It's just not showing on that EKG. So with the STEMI, the ST segment elevation is measured from the J point, and then the elevation greater than 1 millimeter is indicative of an acute MI. So it's looking at, vertically, how high is that elevation? And then the goals, of course, reestablish perfusion to the heart, right? So minimize damage. So preserve function and prevent complications. And getting blood circulation back to that heart muscle is how we do that. So whether it's getting them to the cath lab and getting a stent, or getting them in for emergency open heart surgery, or removing a blockage. So yeah, so the diagnosis would be alteration in tissue perfusion, right, as evidenced by angina, related to I don't want to just say blockage to the heart, related to ineffective perfusion to the heart muscle, as evidenced by chest pain, elevated ST segment, myocardial, you put your labs in there, and other, because usually when you're having a heart attack, right, your color is going to be ashen, you're going to have an O2 requirement. So all of those things would be assessment findings to support the alteration in tissue perfusion related to, perfusion to the heart muscle. Okay, so good. I like that you're already ahead of here. Okay, we got our assessment findings. What would be the nursing diagnosis that we would choose? Good. Okay, let's go ahead and take a break. 3:06, right? Let's come back at 3:16, please.
Thank you so much for answering all my questions. I'm sorry.
I try to get in there and check the chat, right?
I saw that. Yeah, that helps a lot with like the actual nursing diagnoses with the
Yeah,
paperwork
good.
I was
Oh,
doing in
excellent,
clinical.
excellent
Yeah,
question.
okay.
And actually, you're kind of segueing me, right? That one
Oh,
question. kind of
are
segued
you already
me.
leading there? I don't have your
Yeah. I
PowerPoint
was
like
like,
up
all right.
right now. Okay. Thank you so much, Miss Anderson. I really appreciate it.
I'll see you in 10. Get a drink or something. Hi, Shelby.
Miss Erica,
Yes.
real quick. Tomorrow, I know we're meeting at 8:30. I have the Zoom for the simulation tomorrow at 8.
Oh,
Is it?
yeah.
So just in case it takes longer, last time it didn't take all 30 minutes, so I think we still should be able to meet at 8:30. But just to give you a heads up.
Yeah, I'll just wait for you. Okay, I'll have it open and I'll be doing something, and then when you come in, we'll be all good to go.
Okay, I just wanted to let you know. I just thought about that just now. So
Thank you. Thank you. Perfect. We're good. Okay. Welcome back. I don't know what happened to my PowerPoint. There it goes.
I like the orange one.
I like the green background. Oh, the puppy. Okay. Now let's switch over. We're going to talk about congestive heart failure. Okay, when the heart starts to just kind of give out, right? So maybe this is post heart attack. Maybe this is elderly population, right? Or maybe there's been some kind of endocarditis or some kind of or post heart attack, post MI, right? So some damage to the heart, and then the heart's not pumping effectively. And then what does that mean, congestive, right? What does it mean when the heart can't pump out effectively and you got this backing up of fluid that happens, okay? So defining heart failure. It's a condition where the heart is unable to pump enough blood into the circulation to meet the body's needs. What are two main root problems that can lead to heart failure? So you either have the inability to adequately fill, like when you were talking about the heart defect, right? And we're talking about that right ventricular hypertrophy or left ventricular hypertrophy. That would be the inability for the heart to stretch enough to fill, or the inability to pump or squeeze the blood with enough force, right? From the heart, or a combination of both. Maybe it's not able to, fill, and it's not able to pump. So I'm gonna have to wake up my dog too. What is the primary concern or result of heart failure? What's your dog's name, Monique?
It's my mom's dog, but I'm about to take him. His name's Rico.
Rico.
This is his full size. He's tiny.
Miniature Chihuahua? And then
it's a teacup.
Teacup, cute. And Allie, what's your dog's name? I think I should remember.
This is Bandito.
I did not know that. Bambito. Like, hey guys. So primary concern and result of heart failure, reduced cardiac output, right? So that's your nursing diagnosis. Alteration in cardiac output related to either the inability of the heart to pump or the inability of the heart to fill, right? So we wouldn't necessarily say related to hypertrophy of the heart, because we're not the cardiac, the cardiologist going in there and looking at that echo and interpreting it, but we can tell because, we can tell that the patient doesn't have enough perfusion. And we can tell because there's other, there's other labs and things that we look at. When perfusion is reduced, what does the body also do? How does the body compensate, right? So it initiates compensatory methods in attempts to improve cardiac output, but then, which it can also negatively lead to congestion and fluid volume excess in the heart failure patient. So, if the heart's going to try to pump faster to try to get better cardiac output. So if you don't have enough, right, volume, then you're going to try to pump faster, but that's going to continue to overwork the heart and lead to further congestion and heart failure. So it's actually the compensatory mechanism, which would normally be good in the healthy person, is more damaging. So causes of congestive heart failure. You got your three categories. You have your impaired myocardial infarction. So impaired myocardial function. So they've either had a heart attack or damage to the heart muscle in some way, or the heart muscle's giving out. And then you have that increased cardiac workload, right? Or acute non-cardiac conditions. So those three categories. So here's your examples that would fit into each of those categories. So you either have your coronary heart disease, your cardiomyopathies, rheumatic fever that causes damage to valves in the heart, an infective endocarditis, which could also cause damage to the valves of the heart, increased cardiac workload. So if you have hypertension, your heart's constantly having to beat against that increased systemic vascular resistance, or valve disorders that increase the work of the heart because blood isn't going in the right direction, right? It's regurgitating back and things. And then your anemias. So your body's not getting enough oxygen, which is going to cause more cardiac workload because your heart's going to try to compensate for that anemia and try to get more perfusion out, more oxygen out to the tissues of the body. And then you have your congenital heart defects. As you looked at your defects this week, you could see how, again, the heart would try to compensate for not having enough perfusion, and that would increase the workload of the heart. And then your acute non-cardiac conditions, right? We're in there and we're resuscitating, and then we actually give too much fluid, or that person is retaining fluid because their kidneys aren't working or something. So they have this increased blood volume that's circulating, and it increases the workload of the heart. Hyperthyroidism stimulates the heart and increases workload on the heart. Fever, infection, or that massive PE that causes cuts off coronary cardiac output, and then the heart's trying to push against that resistance. And so 2 types of heart failure: systolic, the failure of the ventricle to empty, or diastolic, failure of the ventricle to relax and fill properly, or a combination of both. So remember the pathway of our blood flow, right? From the right to the right to the right to the lungs, right to the left to the left to the left, and it kicks out, right? And kick out that aorta and that perfusion. So the pathway of the blood flow from the vena cava to the right atrium, to the right ventricle, to the pulmonary artery, to the lungs, to the pulmonary veins, to the left atrium, left ventricle, aorta, systemic, and back up to the body, and back up to the heart, through the right, to the right, to the right, to the right, to the left, to the left, to the left, to the left. Now kick, now kick, now kick, now kick, and back to the body, and back up to the heart, right? So if the right ventricle isn't functioning well, if it's not pumping out the right atrium to the lungs well, where is it going to back up to? The rest of the body, with an R, right? Right side of ventricle, rest of the body. It's going to go out to the rest of the body. So what are we going to see? We're going to see jugular vein distension. We're going to see edema in our feet, right? So we're going to see that fluid out in the body. We're going to see weight gain. So blood will not advance well past the right ventricle. So blood's going to back up in the right atrium and then cause venous congestion. If the left ventricle is not functioning well, where's the congestion going to occur? L for left ventricle, L for lungs, right? Blood will not advance well past the left ventricle, so the blood will back up in the left atrium and ultimately the lungs. So what do you think you're going to see? You're going to hear rails in the lungs, right? Wet sounds in the lungs. So remember, cardiac output equals heart rate times the stroke volume, right? The amount of blood that's ejected from the heart times how fast the heart is pumping gives us that cardiac output. It's going to be about 6 to 8 liters. Stroke volume, amount of blood, right? Ejection fraction is what we get as that percent, should be between 50 and 70%. A low ejection fraction is indicative of heart failure. So 3 main compensatory methods to maintain cardiac output. Compensatory methods to maintain cardiac output. The stretching of the heart muscle, that Frank Starling's law. So increase in return, increase in stretch, and increase in contraction. So how the heart muscle functions. Neuroendocrine responses, hormonal responses, that the ROS system. So the renin, angiotensin, aldosterone system. One of my favorite, like, simple nursing guys, Michael Linnaeus, he has this whole little story that he talks about how you got the aldosterone, like aldosterone is the bouncer of the kidneys, and he shuts it down and he retains the water and retains, like, the sodium are the girls, and then the water are the guys, because the girls attract the guys, right? And sodium attracts water. So so we think about, like, then our ACE inhibitors, right? The angiotensin converting enzyme. So remember, the enzymes in the renal system start with the renin, and it converts to angiotensin 1, angiotensin 2, aldosterone. And then, so this is how we diurese and get rid of urine in our kidneys, okay? So then that feedback process with the neuroendocrine system is then if you have antidiuretic hormone, it reverses this process. So this is how fluid is regulated in our body with our kidneys, okay? Have you studied this yet in patho at all? It's coming, you will, it'll tie in, okay? So just hang tight with that. But our ACE inhibitors are, I'm trying to think of, losartan. There's certain medications, blood pressure medicines that you take that are, they cut off how the enzymes convert from one to the other. And so if it's an ACE inhibitor, it's an angiotensin converting enzyme inhibitor. It's blocking that process from the angiotensin 1 to the angiotensin 2. So it stops it. It's antidiuretic. So it's diuretic. It helps us diurese. It helps decrease our blood pressure by getting rid of extra fluid in the blood, in the system. Decrease cardiac output. Kidneys stimulate renin production. It triggers angiotensin 1, which gets converted to angiotensin 2. It's a potential vasoconstrictor and triggers aldosterone and that retention of sodium and with water. So it's the stimulation is from the adrenal cortex. From that, you know, that we have our different endocrine organs, right? So we have our pituitary gland, our pancreas, thyroid, parathyroid, right? Endocrine system. And then we have our adrenal glands. And then you have your sex glands too, right? So that antidiuretic hormone, the ADH, that leads to water retention is triggered as well to secrete from posterior pituitary along with increased thirst mechanism to help us regulate our fluid to retain water. And the central nervous system stimulation triggers norepinephrine that is released to increase heart rate and contractility. So these are all different neuroendocrine responses that help our body compensate to maintain cardiac output. And then there's myocardial hypertrophy. We talked about how the heart will work harder and get bigger. So it increases the workload. That increased workload on the heart leads to myocardial hypertrophy and ventricular dilation. And these mechanisms, so all these compensatory mechanisms that normally would help in a normal healthy person, in the person with heart failure, you can see where it's intensified, and then they get more congestive heart failure, okay, because they're retaining fluid, and then that increases the work of the heart and it makes it worse. So this is what I was talking about, this ROS system. Remember, it starts with the renin, right? Renin to angiotensin 1 to angiotensin 2 to aldosterone system, okay? And there it is, the whole feedback, this regulatory system for this antidiuretic compensatory mechanism in the body. So that's why a lot of people with heart failure, with hypertension, get put on ACE inhibitor, you know, on an ACE, like losartan, the ANS. So systolic right-sided heart failure, if it's on the right side of the heart, it's going to go to the rest of the body, right? What is the typical source and causes of right-sided heart failure? It's typically caused by disorders in the lungs, such as pulmonary hypertension. So if there's that increase at the heart, if the right side of the heart's having to try to push that blood out to the lungs, but there's pulmonary hypertension, so it's not able to push out and perfuse well into the lungs, it's going to put more work on the right side of the heart. And it's going to cause damage to that side of the heart, and then fluid's going to start backing up in the rest of the body. If the right ventricle cannot propel blood forward, where does the blood go? Backs up into the venous system, and then the cardiac output's going to drop. What signs and symptoms are seen in right-sided heart failure? The edema, dependent edema in the feet, swollen ankles, right? They might also have congestion in the gastric vasculature. They'll complain of anorexia, GI upset, jugular vein distension. So when you assess that, you're going to sit your patient at a 45-degree angle, and you're going to look at their neck, and you're going to palpate, and you're going to look for jugular vein distension with their head of their bed at 45 degrees. You're going to look for that. and liver engorgement, maybe even some ascites and some varices, and weight gain and reduced urine output.
I have a question. Would something such as AFib be considered right-sided heart failure because the blood's pooling?
Not necessarily, because there's not damage to the heart muscle. Okay, with cardiomyopathy, there's damage to the heart muscle, and with AFib, it's a electrical arrhythmia. So yes, there's pooling in the blood there, but it does affect cardiac output, but it's not heart failure per se.
Okay, perfect. Thank you.
Yeah, good question. And I think sometimes we got to keep things in kind of in the lanes in our mind, right? So you have your arrhythmias that can also, of course, cause changes in cardiac output and everything. But then this is a kind of a different pathophysiology. Okay, so and then when we're looking at that left-sided heart failure, so what typical causes of left-sided heart failure: coronary artery disease, myocardial infarction are common causes, but anything that impairs that left ventricle and its ability to pump and put out blood. If the left ventricle can't propel blood forward, where does the blood go? It's going to back up into the lungs. And then we still don't have adequate cardiac output. And then we also have pulmonary edema. Okay, so that orthopnea, right? If at night, and what if I have a little bit of both, right? Or a lot of both? If I'm got fluid out in my peripheral system and I already have left-sided heart failure, and when I fall asleep at night, that peripheral fluid kind of tends to absorb back into the vascular system, and then I'm going to have increased fluid in my lungs too. So that's why at night they have to put pillows and sit up more, because they're going to feel like they're actually drowning in their own pulmonary edema. And then they'll have that pink frothy sputum that they're coughing up and stuff too. So congestion in the pulmonary vasculature is then forced to enter into the alveoli. It obstructs gas exchange, secondary to the buildup of fluid, congesting those alveolar spaces, right? So they have that ventilation, right? When we talked about VQ mismatch, that ventilatory mismatch, because with the edema in the lungs, the alveoli can't be filled with air, right? So you have that decreased gas exchange and alteration in gas exchange related to pulmonary edema, as evidenced by, boom, right? Rales in the lungs, need for oxygen, gas exchange, right? When I'm thinking gas exchange, if that person has an oxygen requirement, that's a specific assessment finding that fits with gas exchange, okay? What do their blood gases look like, right? If they can't get the CO2 out, they're gonna have respiratory acidosis, which supports gas exchange as our diagnosis. Alteration, right, in gas exchange related to fluid in the lungs. We could even keep it that simple. We don't have to say pulmonary edema, but you could say pulmonary edema, as evidenced by lung sounds, rales bilaterally, right? You got it, okay? Oxygen requirement, ABG results. High CO2, acidosis, boom. Three good solid assessment findings supporting alteration in gas exchange. So, so when they have increased pulmonary edema, they're decompensating, right? That can be life-threatening. What drug am I going to do to get that fluid out of there? What drug do we see a lot of times with heart failure?
Lasix.
Lasix, yes, furosemide, right? And I know when we go to the adult floors, you don't want to give it too fast because it can cause permanent hearing loss. Okay, tinnitus. They'll get ringing in their ears, or they can have actual hearing loss that won't come back, right? So they say you got to give it over at least 2 minutes, but a lot of the nurses over there believe in you don't want to give it too slow, because if you give it over 5 minutes, it's not as effective. And especially with your patient with heart failure, you want to make sure you're really, so, right around 2 minutes, like 2.5 minutes is like perfect for somebody with heart failure. So signs and symptoms: pulmonary congestion, crackles, wheezes, shortness of breath, cough, blood tinged sputum, fast breathing, having that orthopnea, being fatigued, having that activity intolerance. They might have a S1, S2, S3, so a gallop, because the heart is working that hard that then you're going to hear that third heart sound. Also, women who are at the end of their pregnancy have the increased workload on the heart and can develop an S3. It's kind of a normal finding because it's more temporary. Here, it's more of a sign of increased heart failure. Weight gain, right? We'll teach that patient to weigh themselves every day, same time every day. Look for that 2-pound weight gain. 2-pound weight gain, I think, I can't remember in the book. I think it said 1 liter of fluid. Every 1 liter of fluid is 2 pounds of weight gain. I think that's right. And so reduced urine output because you're going to have that decreased perfusion to the kidneys, restlessness, anxiety because of the, they have that fluid, they can't breathe well. And that feeling, if your patient ever says, I feel like I might die, listen to them. Okay, so here's our cartoons, the right-sided and left-sided heart failure. So you can go ahead and print these, right? Put them by your bed, put them in your bathroom, put them on your refrigerator, put them in your car. Hypertension, the limits for hypertension, greater than 140 for your systolic, greater than 90 for your diastolic. Primary hypertension is you don't have any other health problems causing it. It's just hypertension. And it has no identifiable cause. That's about 90% of cases of hypertension. It's not because they're in renal failure. It's not because of something else. Secondary hypertension is when it is from something else. And that's the last 5 to 10%. They got something else that's then causing the hypertension. Kidney disease. Coarctation of the aorta, right? They got an obstruction in the heart that's causing hypertension. Endocrine, right? They have Cushing's or a tumor. I got a tumor. Neurological, right? So they had a head injury and it's causing increased intracranial pressure that's causing hypertension. Medications. I took too much Sudafed. I got hypertensive. Too much caffeine, right? Pregnancy. I talked about the increased circulating blood volume, pregnancy-induced hypertension, or their hypothyroidism is causing hypertension. Sleep apnea and an increased release of catecholamines, which actually isn't good for the heart. That they're doing more and more research where sleep apnea leads to heart disease and an increased risk for MI. So our modifiable and non-modifiable factors, right? Modifiable is your diet, your salt intake. It's got to be less than 2 grams, which is not very much. Okay, so that could be our homework for today, right? Is to try to limit your sodium by less than 2 grams. And I could even say, we could even say less than, the American Heart Association, they're always making it more tough. What, you exercise 30 minutes 3 times a week? Oh, no. You got to exercise an hour every day, right? And keep your blood pressure less than 120/80, and salt intake less than 2 grams a day. Overweight, lose weight, insulin resistance, hypothyroidism, tobacco use, don't smoke, and don't have stress, right? No stress, that's modifiable. So just relax, get your sleep, and do your your meditation. Non-modifiable, things that you're not able to change, of course, your gender, male or female, your age, family history, your race. So what's considered a hypertensive emergency? Over 180 for systolic, over 120 for diastolic. If that's maintained, it causes damage to the organs. We think about the microvasculature, right? High pressure in that system damages the small vessels, the microvasculature to the eyes, to the kidneys, to the brain, strains the heart, so causes vascular damage. Signs and symptoms, this is interesting. If you wake up with a morning headache, it can be a sign of hypertension. Double vision, getting up a lot to avoid during the night. You can have papilledema, swelling of the optic nerve, and restlessness, confusion, sensory deficit. Okay, that whole list of things that can be, or you can be asymptomatic and be very hypertensive. So, looking at how we approach hypertension, getting those daily weights, looking at the INO, urine output, responsive to blood pressure medicines, electrolytes, take pulses. Are they having any ischemic episodes? And the complications, the coronary artery disease, the chronic renal failure, congestive heart disease, and stroke. That, the vessels in our brain don't like it when our blood pressure is super high. They start bursting, right? Not good. Other comorbidities that are increased with the presence of hypertension, they're listed, okay? Another cartoon for you to print and tattoo, right? Hypertension, you got your blood pressure, affects cardiac output, systemic vascular resistance, and you can see where this whole cascade, okay, so it's out of table 16-47 in your book. So as you're reading it, it will kind of explain that. And then looking at where we can impact this system with medications. Okay, I talked about the ACE inhibitors. your beta blockers also, right? Your ols, your metoprolol, right? And losartan. Okay. So different lab works. So we're going to look at the BMP, the brain natriuretic peptide. It's a hormone released by the heart muscle. It's, if you have a high BMP, it's correlated to pressures in the left ventricle and the pulmonary vascular system. Typical value is going to be less than 100. So the BNP, not a basic metabolic panel, not a BMP, a BNP, brain natriuretic, it's easy for me to say, peptide. Why would a congestive heart failure patient be given a diuretic? So if they have that right-sided heart failure, right, and they got it backing up to the rest of the body, or even left-sided if they got fluid on the lungs, right? We want to get that extra fluid off, right? So poor ventricle function causes fluid congestion and increases compensatory mechanisms to be triggered. Diuretics can reduce excess fluid and help to reduce workload on a weakened heart. So you will see these patients on Lasix. But if they're on Lasix, what else are they probably going to be on? What do we know about furosemide? What kind of diuretic is it?
Sodium potassium.
Yes, because it's a
Potassium wasting diuretic.
Loop, there it is. Loop, there it is, right? It works on the loop of Henle and the kidney. It's a loop diuretic, right? Loop, there it is. Potassium, right? Because it's non-potassium sparing. Exactly. Thank you, Vivian. Why would a patient be given an ACE inhibitor? Because of that RAS system, right? The renin, angiotensin 1, angiotensin 2, aldosterone system, right? I got to get the RAP app. So it's interrupting that, so you don't have that diuretic hormone, so then they will diurese. No vasoconstriction or sodium retention is less strain on the heart. Why would the patient be given a beta blocker? To block that CNS stimulation, and it reduces the workload of the heart. Okay, and then this is that Michael Linnaeus simple nursing that talks about that RAS system. Okay, so have fun with that because it's kind of a fun one, but it's a long one. It's 11 minutes, 11 and a half minutes, so we don't have time for it. How are we doing? 3:45. Okay. Let's go ahead and just kind of get started here. I'm going to find and get into Blackboard, back to Blackboard, and pull up our case studies. Okay. And let's do this Madman activity. Okay, so real quick before we take a break, go ahead and pull up the Madman at number 2 into week 7, okay? And let's do that in class. So how do you guys feel like you're doing with interpreting blood gases? Okay, so you remember your normals, right? So go ahead and I'll give them to you again. Okay, you can kind of do them on your scratch paper, or if you bring this up, you can, so get a piece of paper, and I'm going to pull up these Mad Minute questions. I think there's 15 of them. And we're going to play a game, and whoever gets the most right in the least amount of time, okay? So we're going to have to pay attention to the time. And I'll call time in 10 minutes. And then we'll go over the answers really quick. And whoever gets the most right in the least amount of time wins a prize. So there's a prize on the line. Okay, so remember, first you're going to look at the pH, right? 7.35 to 7.45. Less than 7.35 is acidosis. Greater than 7.45 is alkalosis. Then you're going to look at the CO2, the carbon dioxide. And as I like to call it, it's the carbon diacid, right? So I remember that CO2 is the acid part that our bodies are trying to get rid of through our lungs. So that's a sign of the respiratory function, right? And how our lungs get rid of CO2. So 35 to 45. So if it's less than 35, I'm probably hyperventilating or my vent settings are too high and I have respiratory alkalosis. And if it's higher than 7.45, if it's higher than 45, then I am retaining CO2. So my lungs I'm not able to effectively get rid of the CO2 and I'm acidotic, right? I have too much CO2, too much acid if it's above 45. Okay, so then I determine the CO2 and what's going on with my lungs. Then I'm going to look at what's going on with my kidneys, right? And what I'm doing with my bicarb, with the HCO3. And that should be somewhere between, what do we say, like 16 to 22 or it's always varies, right? 17 to 20, what are we saying?
22 to 26.
22 to 26, okay, good. Okay, 22 to 26. So if it's too low, I don't have enough base and I'm acidotic. And if it's too high, I have too much base and I'm alkalotic, right? So once I've determined that, and I'm going to look at my oxygen and make sure I got enough oxygen in my arteries. Okay. So then once I look at that and I determine if it's respiratory acidosis or if it's respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis, I got the 4 choices. Then I got to look at, is the other compensatory system working, right? So if my bicarb's low and I don't have enough base, am I blowing off CO2 and getting rid of extra acid to at least compensate, okay? So if that is working, if I look back at the pH and it's normal, I've fully compensated. That's the only thing that determines partial compensation versus full compensation. If the pH is abnormal, it would have even been worse if I wasn't compensating. So at least I'm partially compensating. If the pH is normal, then I've fully compensated. Okay, I've actually, let's say I have DKA, right? And I come in and my blood sugar is 400 and I'm having small breathing. And you get my ABG and, my bicarb is 11 and I've got this huge anion gap, right, with my electrolytes. So you know that I have anion gap metabolic acidosis, but then you look at, and I'm actually breathing so fast that my CO2 is like, 28 or something, right? And then you're like, and my pH is actually 7.35, right? Or 7 point, yeah, it's probably still on the low end, right? But let's say it's still within normal limits, so I fully compensated. I mean, that's kind of stretching it because usually I'm still going to be acidotic. I can only breathe so fast. But let's say that it's fully compensated, okay? Does that make sense? Okay, so don't worry about it. Do your best, and we'll go ahead and like I said, I'll give you 10 minutes, and then we'll go through the answers. Okay, so have fun with it. Go ahead. Did anybody open it up? Did you open up early? I hope you didn't. Don't open it early, anybody. And let's see, I gotta share. Okay, I'm gonna call time. And that's okay if you're not done, okay? We'll work on it together. Okay, so number 1, okay, the pH is 7.32. Corey, what do you want to tell me about the pH? Interpret that.
The pH is low. I'm sorry.
What does that mean?
Acidotic.
Yep, okay. And the CO2 is?
It is alkalotic or acidotic, I'm sorry.
Correct. So we have respiratory acidosis, right? So I'm going to put an RA here for respiratory acidosis. And then what about the bicarb?
The bicarb is also alkalotic. So I put
alkalotic. Well, look, because we have respiratory acidosis, right?
Mhm.
So then we look and we say, okay, is there compensation? Because what are the kidneys doing? Retaining? They're retaining base, right? Because you told me the bicarb is high, right?
Yes.
Yes. So do we have compensation from the kidneys?
Yes, partial.
Good job. Yes. Respiratory acidosis. Yep, because we do have compensation, but the pH is not normal. So we have partial compensation. Respiratory acidosis with partial compensation. Piece of cake, right? There. Okay. And let's see, where's my little eraser up here? Oh, wait, erase. There. Okay, next one. Alice? Is it? Oh, yeah. Alice Johnson? Oh, Allison Johnson, sorry.
Allison.
I'm like, oh, that didn't sound right. Okay, sorry.
No, it's okay.
I have to find my pen. Eraser. How do I do the pen? Draw. Does that work? Okay. pH 7.48, right?
pH is high.
So high means?
Alkalotic.
Yep. Okay, and then the CO2?
CO2 is low. So that's respiratory alkalosis.
I broke my thingy. Okay, there. Here are all drawings. Okay. Respiratory alkalosis, and then what's the bicarb doing?
A bicarb is a little bit low. So partial.
Exactly.
Compensation.
Exactly. Very good. Respiratory alkalosis, partial compensation for number 2. Number 3, Alexandria. pH?
Okay, the pH is within normal limit.
That's good.
And the PCO2 is low, so it's alkalotic. And then the HCO3 is 17, and that's acidotic.
Yep. So what do we have?
I had metabolic acidosis full comp, but I'm not sure if that's right.
Yes, it is. Metabolic acidosis with full compensation. Yes, exactly. This could potentially be our person with diabetes, right? If they're breathing fast enough. Yes, exactly. Okay, very good. Number 4, Brittany.
Sorry, I had to find the unmute button. So the pH is low.
Acidotic, yep.
Yes. The CO2 is normal. And the HCO3 is low. So I have it metabolic acidosis with uncompensation.
Exactly, yes. This could be our person who was maybe they were vomiting a lot, right? And losing a lot of bicarb that way, or diarrhea, losing a lot of, base from diarrhea, and they got metabolic acidosis. Yep. And then maybe they have some kind of respiratory issue that they wouldn't compensate. Okay, number 5, Jess. So the pH. Is your mic not working? I can't hear you.
Can you hear me now?
Yes.
Okay. We're doing number 5. The pH is acidic, it's low. The PCO2 is high. And the HCO3 is a little high too. I got respiratory acidosis with partial compensation.
Exactly. Very good. Yep. Yeah, it would have even been worse if, and it takes a while. Remember, it takes a few days for the kidneys to really kick in and start retaining bicarb. So it would have, the kidneys are starting to retain some bicarb. So now it's, it would have even been worse if they weren't, if the kidneys weren't able to have the bicarb on the high end. Okay, number 6, Selena Paco, who is not Selena Pacheco. I apologize, Selena. I'm getting old. What can I say?
You're fine. For number 6, so pH is high, so it's alkalosis. PCO2 is low. And then, so I have respiratory alkalosis. And then the CO3 is going to be low. So I have respiratory alkalosis uncompensated, partially compensated.
Yes.
No, uncompensated, sorry.
Compensated. Yep. So they're not retaining bicarb. Yep. Good. Okay. Are we on number 7? Melinda? Good job, guys.
Sarah, can you clarify that one? Can you say it out?
Yeah, what was 6?
Number 6. Okay. So the pH is 7.51. So that's high. So that's alkalosis. And the CO2 is 29, which is low, right? So they're blowing off CO2. So they have respiratory alkalosis. And then the bicarb is on the low end. If we're saying I know it's right on the cusp, right? So if you wanted to say that, yeah, so they're not retaining bicarb, right? The bicarb's not high.
Yeah.
So there's no compensation. Respiratory alkalosis with no compensation,
Okay,
right?
Yeah, that's what happened.
It was just, it wasn't that it didn't understand. It was just didn't hear what you said and got confused and was like, wait a minute.
Cool. Thank you.
You're welcome. Okay. So, and I lose my place all the time. We're on number 7, correct?
Yes.
Okay. Go for it, Melinda.
Okay. All right. So the pH is normal at 7.45. The PCO2 is low, which would mean it is alkalotic. The HCO3 is low, so it's acidotic. And I'm not sure I got this right, but I put respiratory alkalosis, sorry, fully compensated.
You are absolutely right. Yes. Yep.
Thanks.
Sometimes you have to look at what is the pH, where is the pH though? Is it on the high end of normal? And then it's the respiratory issue and the other one's compensating. And you got to kind of figure it out that way. Yep. So you did it exactly correctly. Respiratory alkalosis with full compensation. Very good. Okay. Number 8, Tamara.
Okay, I really didn't get to this one, but the pH is acidotic. The PCO2 is also low. And the bicarb is also low.
Right.
So I'm gonna go with metabolic acidosis, partially compensated.
Absolutely correct. Perfect. Very good. Okay. Boy, you guys, you're on a roll. Okay, Chanel or Sarah, number 9, please. Where'd you go? You disappeared.
Okay, sorry. You can hear me, correct?
Yes.
Okay, so the pH is a little bit high, so it's alkalotic. Your PCO2 is slightly high as well. And then your bicarb is slightly high as well. I put metabolic wait, no. It would be metabolic alkalosis, partially compensated.
Exactly. Very good. Okay, number 10, Bridget.
So the pH is going to be high, so it will be alkalosis. The CO2 is normal, but on the low end. So I put metabolic alkalosis, and then the HCO3 is high, so I said it was uncompensated.
Metabolic alkalosis because the bicarb is high. You're right. So bicarb's high, pH is high, bicarb's high, right? Metabolic equal. So it's metabolic alkalosis. And then because the CO2 is within normal limits, they're not compensating. You're correct. Okay. Number 11, Mariah.
Okay, I didn't get to this one yet, but hold on. So the pH is gonna be within normal. The CO2 is also normal.
Yep.
And then the bicarb is high.
A little high, yeah.
So I would say metabolic alkalosis.
Yeah, you might think that, but the pH isn't that high, is it? So really, it's kind of normal. They just have a high bicarb. It's tricking you, but it's normal with a little bit of a high bicarb. So we'd want to find out why their bicarb's a little on the high end, but they don't really have an acid-base imbalance.
Oh, okay.
It's a little tricky, I know, because of the bicarb being a little high.
Yeah.
But I would interpret that one as normal.
Okay.
You could argue it and say, but if the bicarb is high and their pH was high, then yes, it would be a metabolic alkalosis, but the pH is normal. Okay, number 12, right? Are we on 12? Monique?
Um,
7.45 is the pH?
I thought we were on 12.
Yeah. Isn't it 7.44?
Yeah.
Okay, sorry.
Right?
Yep.
So it's normal.
Uh-huh.
The CO2 is high.
Mm-hmm.
The CO3 is high. So it would be, sorry, it takes me longer. I feel like my brain isn't all the way back yet. So it would be compensated. And it would be alkalosis.
Yes.
And it would be respiratory, right? So respiratory alkalosis compensated.
If the CO2 is high, the CO2 is acid.
So I keep getting these numbers mixed up. I keep looking at 13. Okay, CO2 is high, so then it would be CO2 is high. That's normal. I think this cheat sheet that I'm looking at gives way too much. I need to find like a simpler one. So then what would it be then?
That's
compensated.
Right, it's alkalosis.
So it's metabolic alkalosis instead of respiratory.
Yep. Because the respiratory would be acidotic, right? So it's metabolic alkalosis and it's fully compensated because the pH is actually on the high end of normal, right? So metabolic alkalosis with full compensation. Yep. Okay. And then just to finish up, so number 13, the pH is 7.21. So that's acidosis. The CO2 is super high, 73, right? And then the bicarb is as high, right? It's above 26, it's 28. So we have respiratory acidosis with partial compensation because the pH is abnormal. But if we weren't getting that bicarb up, it'd be even worse. 14, 7.31 is acidosis. The bicarb's super low, right? 11. So we have metabolic acidosis and the CO2 is within normal limits, 35 to 45. So there's no compensation. 15 is normal. And 16 is very severe respiratory acidosis. that could be like a patient that maybe a submersion injury or something like that, right? Where they pulled the child out of the pool or something, with some partial compensation, right? Because the bicarb is high. So this could be maybe days later when the kidneys kicked in or something like that. Okay, so go ahead and take a break and private chat me how many you got right in how many minutes.
Did you post the answers for these?
Stacy, I think she said she was going to post them next week.
Thank you.
Okay. Okay, everybody, let's go ahead and finish up. And I just want to prep you out for this week's outside class activity. Remember, we are going to have a quiz on central perfusion and exemplars. Okay, so looking at those exemplars, heart failure and angina. So this week, our case studies are going to be on pulmonary embolism, deep vein thrombosis, and stroke. We're looking at occlusive disorders that affect central perfusion. Okay, I have posted articles on each exemplar from our concepts. So when you go into the concept, into Walter Kluwer's Into the Point, and you go into the concept library, there are resources on PE, DVT, and stroke there for you. And
Ms. Erickson,
yep.
the due date here, you want it done by October 25th, right?
Yes. Well, is it October 25th? Let me see. What's next week? I want it done by the Monday at midnight before class. Sorry, guys. I gotta pay attention to when I put dates on here. So next week is the 27th. So yeah, October 26th, midnight. Okay, so our next class is October 27th. This is due midnight the 26th. So I will make sure I post that, and I'll put a folder in the discussion board, and I'll make sure I got the correct date on there also, and I'll edit this, repost it. Thank you for noticing that. Okay, midnight, the end of day on the 26th. Okay. So I have you all assigned. We're gonna go with our male nurses, our future male nurses as our team leaders. Not that we don't have more men than this, I know we do, but these are this time around, right? So Robert and Trevor, you get the week off, right? So Nathan is gonna be team 1 team leader. So guys are gonna be responsible for putting it all together and posting it in the discussion board. So we got Nathan, Thomas, and Brett. Part 1 is going to look at building up details of the case study and working on the assessment aspects of inspection, palpation, percussion, and auscultation. Part 2, you're going to look more at the history and the questioning and diagnostics in labs, and then choosing the top three priority diagnoses. And then we have team 1, team 2, and team 3, because we have 3 different exemplars, 3 different case studies. And then part 3 is going to be the plan of care for those top 3 diagnoses, doing the short-term goal, the independent, what does the nurse do on your own in terms of positioning your patient, further assessments, when to call the doctor, and then collaborative interventions like giving medications as ordered, and working with respiratory therapy, right? Or physical therapy, or whoever is your other members of the team that we're collaborating with, okay? And as well as priority teaching interventions, right? What are you going to teach? So put that into those interventions. You know, if you're teaching the patient to weigh themselves every day, or if you're teaching the patient how to, anticoagulants to prevent another PE. Make sure you're using specific, measurable, attainable, realistic, and time frames throughout your care planning. Okay, so team 1, and so we got team 1 in 3 parts, right? So Carrie King is your 25-year-old female who recently underwent a right hip replacement surgery, secondary to congenital hip dysplasia. She's a dancer, and she was experiencing more pain and hip clicking with her daily activities. She's also been on birth control since she was 16 years old. After her assessment with her physician, she was informed that a full hip replacement was the only option to assist her in regaining full use of her leg. Following her hip replacement surgery, she's sent home, and on her 4th postoperative day, she was supposed to be doing these Lovenox shots for 21 days, and she was informed to follow up with outpatient rehab to regain full strength and use of her right leg. She attends her physical therapy appointment, and 15 minutes into the therapy, she begins to complain of shortness of breath and pain in her chest. The physical therapist stops the therapy, calls 911. In the emergency room, Carrie's hooked to a cardiac monitor, and her pulse ox reveals 87% on room air. They put oxygen on her, labs are drawn, physical assessments done. She informs her nurse that she stopped doing her Lovenox shots 3 days before because they really hurt her. And then she's diagnosed she has a pulmonary emboli, okay? So, this is kind of in the acute care setting, right? So you're looking at but it's not like she's dying. Okay, small PE. But so she's gonna be put on anticoagulants and it's going to resolve, but take me through that, what you're assessing for and everything. Tiffany Pepper, number 2, 31-year-old heavyset female. She travels a lot from Tokyo for business. She's currently in her 2nd trimester of pregnancy, seeing her OBGYN for her follow-up appointment. When she's asked how she's doing, she divulges multiple complaints. She informs you that her job is more stressful lately. She's not been able to stop smoking. She almost didn't make the appointment because her flight home from Tokyo was delayed, and it landed this morning. And then she notices she's got this swelling in her left leg, seems to be greater than her right. And her OBGYN sends her to the emergency room for workup, and she's diagnosed with a DVT in her left leg. Okay, so that's number 2. Number 3 is Melvin Roberts. He's a 78-year-old male. He has AFib for at least 3 years. His cardiologist prescribes him 25 milligrams of metoprolol twice a day, aspirin 81 milligrams daily, and 3 milligrams of warfarin PO daily. He follows his doctor's prescribed regimen to a T because his wife states she wants him around a little bit longer. His wife has started the 2 of them on a healthier regimen and has started integrating more salads in their diet, more walking in their daily routines, and volunteering at the local animal shelter. One day, while driving to the shelter, Mrs. Roberts notices the car is starting to drift. She tells Melvin to stay in his lane and notices no change. She looks at him and notices something is wrong. She assists him and he pulls over, and they call 911. And in the emergency room, he's diagnosed with a left-sided stroke with a CVA. Okay, so those are the three different scenarios. So you're going to take those and you're going to build on them and you're going to go with it and have fun with it in your teams. You got lots of people on each team, right? You have at least 9 in each team. So, so you can kind of split each part up, right? And go into some depth with it, get some detail in there. Okay, you guys want to, look at the rubric also? It's kind of just a basic rubric, okay? I'm just looking for content, teamwork, presentation, being on time, showing me research, show me the studies, right? Look up, use your resources. So make sure you've done your research, everybody participates, use your textbook as a source, ask questions that are asked, full understanding of the topic, whether it's PE, DVT, or CVA, or stroke. You cover all aspects of the assessment completely. You choose your priority NANDA diagnoses based on those assessment findings. You identify teaching interventions, right? And we're going to present these, and you're going to present them like you did this week in interesting, ways that show that you understand what you're talking about. Right? The simpler, the better. Okay. Do you want me to get you in teams? They're kind of big teams. It might not work too well. What do you think? You want to just kind of make a list of who's on your team and email each other after class and kind of get together like that? Because we only have that much time. So by the time we get you in teams, it'll be time to go. So, okay. And I will be posting the answers to the ABGs, to the MAD minutes, so you can look through those. And, I might post a time where if somebody wants to come into a study group or something, for any of you that feel like you don't quite have this, we could probably do like a Zoom meeting and work, for those who want to just work on ABGs a little bit, you could do that. Do a tutoring session. Okay, questions. So this is due the 26th, end of day, Monday before class. We have a quiz next week. This can be a PowerPoint. You also see here that I do have, what did I do with my articles? I had articles. I'll have to post the articles. I have articles on DVT and PE and stroke. Thought they were there. I'll put them in there. It's easier to have them posted in the folder than it is to go looking in those concept libraries and under all the exemplars. Okay. So that's all I got. Watch for the answers to the Mad Minutes. Watch for the articles on each of your exemplars. Work outside of class on your case study presentations for next week. Quiz next week. Keep up with your reading. Keep working hard. Okay, I'll hang. You guys are free to go. Thank you. And Melinda, I'm going to shoot you an email by the end of the day, okay?
Sure, no problem. I have a quick question on today's worksheet. I was wondering, are there ever two different answers to it, or is it always the same? Because
yeah, that's a great question. You can have a mixed acidosis or mixed alkalosis, like you could have it be both respiratory and metabolic.
okay, because I'm having a little bit of a tough time because I did do this earlier, so because I thought it was due before class, and so I did it. But I was also using one of the slides that Miss Arnold has that has the arrows and things, and so the ones that I miss are different than what that table shows.
Give me an example.
Like number 3. What I originally got was respiratory alkalosis fully compensated, but you said the answer is metabolic.
Because the pH, okay, wait. Yeah. So respiratory alkalosis fully compensated. But if it was, okay, so if they're alkalotic.
See, I'm having a hard time figuring this out. So I'm trying to figure out some way to do it so that it's consistent with everybody.
Right. So what, like, remember when I said you have to look at the pH and if it's leaning more toward lower or higher, right? So, right. So since the pH is 7.35, see how it's really more toward acidosis.
Okay, but it's still within normal though.
Right. But that's why I'm saying it's metabolic acidosis, well, full compensation respiratory.
Okay, so how do you tell the difference? Because
if
like I said, it's two different things.
Because you said respiratory alkalosis. If it was respiratory alkalosis, the pH would be on the high end of normal.
Okay. And the pH is on the...
It's not going to fully compensate all the way over to it being that low.
Okay, because it's still, the pH is...
it's almost low. It's almost acidotic, right?
Yeah, the pH is normal, almost acidotic, but I thought that it didn't matter if it's, as long as it's within the normal.
Right, to determine full compensation.
Okay.
But that's how I'm determining if it's metabolic acidosis or respiratory alkalosis, is that it's more on the acidosis side of it. That means it's...
See, and if I had done this without the slides, I probably would have, since you know, I did the tic-tac-toe method and you've got one in each section, I probably would have gone the metabolic route, but that doesn't line up with what she's got in her slide. And so I'm just...
What way, I wonder?
I can send it to you.